next guest faculty is Dr. Kumar Shah from Pune. He has completed his UG from D.Y. Patil Medical College, Kolhapur, PG from Grant Medical College, Mumbai, and completed his fellowship from UNESCO. He has delivered various talks in national and international conferences on pelvic floor ultrasound and musculoskeletal ultrasound and UAG for uncommon and rare disorders. I will welcome Dr. Kumar Shah sir to deliver his talk.
To see so many radiologists interested in musculoskeletal ultrasound, and I'm honored to deliver a talk on this dais as it is being shared with my mentors Bipin sir and Nidhi madam. Let's begin with some of the applications of ultrasound for traumatic disorders in the musculoskeletal system. Why ultrasound? We have been traditionally using X-ray imaging for diagnosing fractures, and that is our equation: X-ray is equivalent to fractures. And what is ultrasound going to tell us? The story doesn't end there. We can diagnose much more, especially the soft tissue lesions. And novel applications like elastography are useful in this regard. And ultrasound has important applications with respect to trauma to the immature skeleton, which I'll be discussing few cases. Let's see some cases, region by region. Now, rib fracture is a very common entity in our clinical practice. These all cases have been done in a setup which is not a tertiary care or a very high-end kind of a hospital. This is in a simple diagnostic setup which all of us work in. Chest X-ray was normal, and you can see there is mildly displaced fracture involving the rib. There is a cortical breach and there is mild displacement. Just to compare a normal rib on left side. Again, normal chest X-ray. There is a breach in the continuity of the cortex. We can see on a panoramic view, normal cartilage, costochondral junction intact, normal, and there is a fracture out here. This is a panoramic view. This is important to differentiate between rib fracture near costochondral junction and costochondral dislocation, as costochondral dislocation of the first rib may lead to thoracic outlet syndrome by compressing the neurovascular structures there. So we can see here there is a normal side and there is a fracture. The junction remains intact. This was a very peculiar case. This patient had met with trauma 2 years back and he had pain on and off since then. Chest X-ray was done, and curiously, we did his ultrasound. We can see that the intercostal space on the symptomatic side is reduced. This is the normal one. Again, reduced space. We can see the video here. There is angulated malunion of the rib causing impingement of the structures in the intercostal space, and we can see the structures are squeezed out of the intercostal space, and this was causing the pain. I repeat, there is angulated malunion of the rib, decreasing the intercostal space on this side. Costal cartilage fracture can be seen on ultrasound because it is not evident on X-rays. You can see there is an infolding of the soft tissues at this level, and this is the normal side for comparison. She is a physiotherapist and working extensively throughout the day. This is the upper trapezius muscle. You can see some hypoechoic areas within this muscle, 1, 2, 3 here. And we can see them on elastography, like these appear as hard areas. This is a color coding done in elastography. Hard is blue, soft is red in color. And I'm using very simple and crude terms so that, and these are called trigger points, and this is a part of Myo-fascial pain syndrome. And this is a very common entity. We can see them in even most of the medical professionals who are surgeons and radiologists and so on. We can study the trigger points on elastography in this case as well. We can see that there are multiple trigger points in this case. We can study the strain ratios as well. On grayscale, we can also see them on grayscale. This is in Pectoralis major. We can assess the post-treatment, evaluation of these trigger points. This is again trapezius muscle, and we can see this is hard area, as we can see this is on the color scale. And post-treatment, we can see those areas have changed to green and red. So there is an improvement post-treatment. So ultrasound elastography is a useful tool to assess the response to the treatment. Again, another parameter, increase color flow here. And there is a trigger point at this area around a vessel. Size is absolutely reduced here, much better seen on elastography than on the grayscale. Now I have included these cases here because, of course, it is not a traumatic disorder, but injection-related trauma is known, and there is a greater role of autoimmunity in diabetic insulin injection lipodystrophy. This patient had poor glycemic control, and you can see that there is a discoloration, and we all know that these patients usually inject at the same area, and there is less of rotation. We can see that there is cutaneous thickening. This is a normal image, normal subcutaneous fat and skin. You can see there is cutaneous dystrophy. There are multiple hyperechoic nodular areas. These are nodal. This is a lipodystrophy. On elastography, we can always compare and see wherein the grayscale images are equivocal or there are no signs seen on grayscale images. These are the clinical pictures. Again, few areas, hyperechoic nodular areas. This is over abdomen. There is hypertrophy. You can see that there is increased thickness of the subcutaneous fat as compared to the normal area. So it is very obvious on ultrasound. Arm. There is lipoatrophy in this case. You can see hardly any fat in the subcutaneous plane. On the contrary, patient was injecting into the muscle, and absorption through a muscle is much greater than through the subcutaneous fat, and this may lead to hypoglycemic episodes. Here there is focal muscular dystrophy as well. We have studied this on elastography. There is multilayer dystrophy in this. Skin, subcutaneous fat, and muscles all are affected. There is diffuse atrophy of the muscle, and you can see this in this image. On thigh. Just to enumerate what are the findings, and all these lead to poor glycemic control except the muscular dystrophy. So the cause of poor glycemic control may lie in insulin induced lipodystrophy, and this is very common. We are going to be diabetic capital, and I would be very happy if we extend this application in day-to-day practice. These are the areas. We can do a subcutaneous mapping of these areas using ultrasound and draw a picture like this and give the report. Let's go to some other injuries. This is also a very common injury. Those who are doing regular exercises and in sports people, the bowlers, this is called side strain injury. There is disinsertion of the fibers of internal oblique muscle from its attachments to the lower ribs and respective costal cartilages. You can see the normal side. This is the abnormal side. You can see a hypoechoic area with some fluid there, and this is seen on the opposite side of the bowling arm in the bowlers. So this is side strain injury, and this is very common. It's a strain injury of the muscle, and this person is a regular gym visitor, and it is overexertion related, and it's an indirect trauma to the muscle. You can see certain hyperechoic areas as compared to the normal side, and this is well detected on ultrasound. This patient was referred to us for ruling out a hernia. Now we must comment on pseudohernia. What is a pseudohernia? There is atrophy of the muscles due to denervation post-surgery, and we can see that the muscles on this affected side are atrophic as compared to the opposite side. You can see there is significant difference in the thickness of the muscles. So there is no herniation of any of the intraabdominal contents. So this is pseudohernia. This patient was on anticoagulants for deep vein thrombosis, and he had bronchitis due to violent coughing. He developed this kind of a hypoechoic collection within rectus sheath, and this is rectus sheath hematoma. We can see the source of the bleeding also on color Doppler. And this is a panoramic view to show the opposite side. This lady had met with a trauma 3 weeks ago, and she presented with a swelling over lower back, and this was a collection scene. We can see there's some there is a fat in a necrotic phase. MRI was done. We can see it's a bicarbonate structure with capsule which is hypointense. And these are called Moro-Lavallee lesions or seromas. This is due to degloving injuries, and there is a dead space created and the collection doesn't get absorbed. This needs to be treated. This is early Moro-Lavallee lesion where the liquefaction still is in process. We can see the fat, again pseudocapsule being formed, very classical location, the deep subcutaneous fat and the Myo-fascial plane. It's a very classical location, and that's how we differentiate just from the fat necrosis, which could be seen anywhere in these layers. It's a panoramic view involving the entire length of the leg, a large Moro-Lavallee lesion. This lady had been referred for abdominal ultrasound and she had suprapubic pain. Now, on asking the history, she had delivered a baby, and we can see that there is cortical irregularity at the symphysis pubis and there was a probe tenderness. We did the exages for confirmation later. So this is a scenario, this is a situation where ultrasound helps us. It would have been very easy for us to just look at the bladder and routine structures and say that, we cannot find the cause of the pain. And here where the, ultrasound plays a role. Musculoskeletal ultrasound plays a role. This patient was an aspirant to join the police force, and he had again a similar complaint for months. We can see that this is the symphysis pubis. There is a cortical irregularity, and this is the tendon of the rectus muscle on either side, and we can see that there is thickening and there is calcification on both sides. There is a partial tear here. This is athlete's pubalgia, and also it is called rectus adductor symphysis syndrome. You can see the anatomy here, seen much better. As we discussed, that this is considered to be a common aponeurosis nowadays, and this is the rectus abdominis and this is adductor longus. Let's go to some of the upper limb lesions. The shoulder must have been extensively discussed with the rotator cuff, all the pathologies yesterday. Elastography plays a vital role. This seems to be focal tendinosis, but on elastography, these areas show a tear. Of course, essentially for this kind of lesion, the treatment would not much differ, but it's just to mention that, especially in the full thickness tears, elastography can play a role where we can miss them on grayscale ultrasound. The point to mention here is that. This is a normal supraspinatus tendon, how it looks. It looks relatively harder, homogeneous, no red areas or very few green areas, and there is no evidence of any degeneration, as we saw in the earlier picture. There is a history of trauma to this patient, and you can see that there is a malunited fracture of the greater tuberosity, which is impinging on the supraspinatus tendon, leading to tendinopathy. And we can see a step-off kind of a thing here. This has been covered. I'll just skip this part. This lady had complaints of pain on and off since last 2 years and had a bunch of x-rays done. And she had been referred for ultrasound, having faith in ultrasound by an orthopedician. And we could see this lesion, the spinal glenoid notch. You can see that infraspinatus muscle on the ipsilateral side, on the symptomatic side, shows atrophy. This is echogenic, bright, as compared to the normal side. And this is the location of the lesion, confirmed on MRI. And this is a paralleval cyst due to glenoid tears. So this is not that common, but again, ultrasound plays a very vital role. Patient had been suffering for 2 years, and this was a game-changing, step for her that the ultrasound was advised. This patient was working in a construction site, and he had comminuted fracture of the humeral head, which was treated with open reduction and internal fixation. He complained of reduced abduction and pain since last 6 months, and they had planned manual, manipulation under general anesthesia, and which could have been disastrous in this situation. You can see that there is reduced sub-acromial space leading to impingement of the supraspinatus tendon due to malunited fracture, and you can see there is grade 1 atrophy of the supraspinatus muscle on the symptomatic side, and there is full thickness partial with tear. The manual, the manipulation under general anesthesia would have been disastrous. It perhaps would have led to a full thickness tear. So ultrasound plays a very important role in such situations. The radial head fracture wasn't evident on X-ray. We suggested ultrasound and we can see the fracture here. We can demonstrate the ultrasound counterparts of fat pad signs which we see on X-rays. You can see that there is a fluid collection and displacing the fat pads anteriorly as well as posteriorly. Tennis elbow has been extensively covered. Just to mention, role of elastography is an early golfer's elbow. We may not get the changes of all those hypoechoic areas and partial tears and so on, thickening, but we can see that the elastography shows reduced stiffness, and this is a very early golfer's elbow. He was a radiologist, this patient, and we can advise them that to take appropriate measures. This patient has met with a distal radial fracture, and there is evidence of distal radioulnar joint instability, which we can detect on ultrasound. This is the ulnar head. This is dorsal aspect of the distal radius, and we can measure the distance between the two, which is increased on symptomatic side. You can see the distance is much more than the normal side. This is a triangular fibrocartilage. This is normal. You can see nicely hyperechoic, and there is a cleft, hypoechoic cleft within the same. And this is secondary to the ulnar styloid fracture, and there is a triangular fibrocartilage tear. You can see a breach in the continuity of the cortex here at the base of the ulnar styloid. We can even see whether it is base or tip or the body of the styloid. All those things could be documented with ultrasound. X-ray is not really conclusive. Quervain's tenosynovitis has been covered extensively. Just to mention, Wartenberg's is a neuropathy of superficial terminal branch of radial nerve, and there is fusiform thickening as a result of trauma due to IV infusions or injections for even Quervain's disease, and this has to be kept in mind where there is a persistent pain in spite of treating the patient with Quervain's or any other disorder of the wrist. There is overuse tenosynovitis of the compartments of the wrist, dorsal compartments. This is proximal intersection syndrome between the first and the second compartment in this. We have seen the anatomy yesterday in detail. There is thickening of the synovium, increased vascularity, all the signs of tenosynovitis, and this is proximal intersection syndrome. Proximal is between first and second. Distal intersection syndrome occurs between second and third compartments with the respective tendons. I'm just running through because of lack of time. This is distal intersection syndrome. Again, the signs are the same, just the location is a little different. We can even pick up the intracompartmental septum in these situations. We can see the septum and multiple slips of abductor pollicis longus. So this is the beauty of ultrasound. We can pick up a lot of things. Madam mentioned about Gans canal, and it is Gans canal syndrome is injury to a distal ulnar nerve, which may occur through compression, inflammation, trauma, or vascular insufficiency. Ulnar artery thrombosis, where repetitive trauma is there, eventually results in injury to the ulnar artery and leads to thrombosis or aneurysm. As in this case, there is ulnar artery thrombosis and the ulnar neuropathy. So this is Gans canal syndrome. This patient had come for an X-ray and he still had persistent pain. We did an ultrasound and we could find there is a trapezoid fracture, a very small chip, seen here. And this is again the beauty of ultrasound. Increased vascularity, all the signs we can see. This is my relative who had met with a trauma, and there is dorsal dislocation at proximal interphalangeal joint noted. You can see it very clearly. There is some radial subluxation also. There was a considered line of treatment given with body strapping, and you can see that there is a reduction, but there is slight hyperextension here. We did ultrasound, keeping that in mind. We can see there is volar fibrillate avulsion fracture. This is the fractured fragment. This is the base of the middle phalanx. And in neutral position, this is the distance which increased on extension. So this indicates an unstable fracture reduction. So this made us think to go for a surgical line of treatment. Also, there was partial tear of the radial collateral ligament. And this patient was treated with anchor and external fixator, as we see here, surgically. This is a ultrasound 3 weeks after the surgery. We can see nice union of the bone fragments here, nice healing. Stenoid lesions, we are all aware, and believe me, the orthopedicians would always want you to diagnose these lesions. They'll be very happy if you are doing this. What is a sternal lesion? There is displaced complete tear involving the ulnar collateral ligament of metacarpophalangeal joint of the thumb. Sounds very, very confusing and very difficult to learn. This is the radial collateral ligament, ulnar collateral ligament, and there is tear of this ulnar collateral ligament, and the there is adductor aponeurosis which interferes in union of this ligament, and that is the reason this has to be surgically treated. There is no conservative line of treatment for this disorder. This is meant for surgery. So we have seen here normal side, abnormal side, the thickening, and complete tear as we can demonstrate. Pulley lesions, we all are aware there are multiple pulleys. This is a Quervain pulley at the level of metacarpophalangeal joint, and we can see some bluish discoloration here. There is thickening as compared to the normal side, and elastography plays a role where there is trigger finger, and if their fibrosis has set in, we can detect it as a hard or a stiff structure on elastography, and again there is a surgical line of treatment for it. There is no conservative line of treatment with injections or anything for that. So elastography again playing a vital role here. There is a sagittal band injury in this case. You can see the cutaneous discoloration on either side. This patient was doing exercises, and you can see the normal side as compared to the abnormal side. There is thickening and there is a tear. You can see. This is just anatomy. I'm not getting into the details of the anatomy of the sagittal bands, just to mention. This patient had met with a penetrating glass trauma due to a glass injury, and she had a discoloration here. This is the superficial palmar arch seen on Doppler, and there is a hypoacutic lesion seen out here. This is a thrombopseudoaneurysm of the superficial palmar arch, and we can see this superficial and deep arches, and how, of course, there is hardly any treatment needed because it is already thrombosed on its own. Let's look at some of the. This patient again was a police aspirant, and he had to run and pass those tests, all those with all those criteria, and he used to have pain on running, and he had met with a injury to a shot put few months back. We can see that there is a scar involving the rectus femoris. This is the normal side, abnormal side, axial scan and longitudinal scan. You can see the scar, and it is encasing the neurovascular bundle. So patient used to have pain, and this was the cause. The scar was the cause of his pain. Posterior cruciate ligament tear, of course, ultrasound is not the modality to diagnose, but we can still see them in a situation where MRI cannot be done. This is normal PCL. We can see the thickness is around 5 millimeters. It is thickened, hypoechoic, irregular, heterogeneous. It is 10 millimeters. There are size criteria to diagnose this. Again, a normal posterior cruciate ligament of the knee. Jumper's knee, chronic overuse is there. He himself was a family physician having pain since 2 years and had been labeled as osteoarthritis. We did ultrasound and the diagnosis was made. Chronic medial collateral ligament injury. You can see increased vascularity, all the, as compared to the normal side. Of course, this has been extensively covered, so I will not emphasize on this much. This patient had met with trauma 5 years back, and he had complaints of pain and weakness. We can see there is lateral gastrocnemius muscle, and this is the medial head. We can compare the two heads. This is much bright. There is fatty atrophy, and the thickness is reduced, and this is due to denervation injury. This is isolated medial gastrocnemius muscle neurogenic atrophy, the final diagnosis. This patient had been referred to rule out a Tendo-Achilles tear, and they felt that there is a gap felt on palpation. So the orthopedician wanted us to know what is the status there. So this is the subcutaneous fat, this is skin, and we can see there is cleavage plane right from running from the skin to the muscle here, and we can see this is a fat fracture. Till then I never knew that such an entity exists, that fat fracture. Tendo-Achilles rupture, of course we all know, this has been covered. what I intend to mention is that there is always an underlying degeneration in almost all the cases of Tendo-Achilles rupture. So we can study them on elastography. This is a normal tendon and this is an abnormal tendon, wherein we can see that these are red soft areas and significant amount of tendon degeneration, especially in diabetics. I take the opportunity to look at the tendons whenever the patients are referred for Dopplers. So you can see this is early degeneration, and ultrasound plays a role to prevent such tears by modifying their exercises or any other kind of a physical therapy. This is a acute left-sided anterior-talifibral ligament tear. You can see affected side, unaffected side, increased vascularity, heterogeneity, thickening, all signs seen here. This patient has an avulsion fracture of the lateral malleolus, and there is a chronic pain. You can compare the two sides. You can see the avulse fragment here. We did stress ultrasound for this patient. Stress ultrasound is using specific maneuvers. In this patient, we did plantar flexion and inversion, and we could see that the distance of the ligament is increased. So there's a chronic tear, and the ligament becomes very lax, and this leads to chronic ankle instability. And this is very common because ray tears are common in 30% of the patients with ATFL injuries. So we have to bear this in mind, and we'll get a lot of patients who come for X-rays, and we must take an opportunity to look at the ligament in these situations. This patient had undergone a surgical intervention for fibular fracture, and he had again pain, and for 2 years, and we could find in ultrasound that there is a evidence of neuroma involving the superficial perineal nerve. This is a longitudinal scan, axial view, and associated there was a hernia which was not allowing it to heal. So there is muscle hernia with neuroma. All kinds of permutations we get. Hagelin syndrome per se is not but there is a chronic microtrauma involved, so I've just included this case here. It's a triad of insertional Achilles tendinopathy, retrocalcaneus bursitis, and Hagelin's deformity. We can see all the three things on ultrasound: bursitis, tendinosis, and the exostosis here.
May I interrupt you, Samir? That's a fantastic presentation.
Yeah,
there are some cases for demonstration.
Sure.
So could we wrap up in another 2-3 minutes?
Yeah, sure.
Thank you.
I'm at the end of the
presentation. Lovely.
He's a driver with chronic heel pain. As an X-ray, you can see the spurs, and it was very evident. But he had pain on a medial side, so we did an ultrasound, and we can see that this. It is little heterogeneous, and we can see these linear hypoechoic areas within the heel fat pad, and this is a normal heel fat pad. This is plantar heel fat pad syndrome, and the pain was not due to the spurs, but due to his, just to mention, his plantar fascia was normal. There was no element of plantar fasciitis, which otherwise one would feel, and this is plantar heel fat pad syndrome. Foreign bodies could be easily detected using ultrasound. We can use even color twinkling and spectral twinkling to detect the foreign bodies, and even elastography. Of course, this is an obvious foreign body. In isoechoic ones, we can detect the foreign bodies very easily, and we can even get kind of a reverberation artifact on elastography. Pediatric and adolescent disorders, very useful. Is an infant with trauma to the chest. We can see there is a swelling here. And the mother was very much anxious. We could see that this is a cartilage fracture. This is angulation of this cartilage. This is a normal side cartilage. We measured the angles even. Just to give you a reference image from the literature for this. This boy was a bowler, and he had pain over the anterior shoulder and tip of the acromion. We can see there is calcific tendinosis due to partial tear of the pectoralis major tendon on both views. And interestingly, he had thickening of the apophysis with fragmentation of its ossification center. And this is termed as traction apophysitis of the acromion with pectoralis major calcific tendinosis. This was the final diagnosis. This is very important to diagnose at this stage, because this may lead to the traction apophysitis. If he continues to play without any adequate rest, he may develop an os acromial, which leads to sub-acromial impingement and supraspinous tendinopathy and tears, and he may require surgical intervention at the midst of his career in future. So this is very important, and ultrasound plays an important role here. Again, just to detect a torus fracture in an immature skeleton, we can see it here, just to detect a ulnar styloid fracture. Pubic epiphysis in a 12-year-old footballer. We can see the thickening of the epiphysis, cortical irregularity here. A young hurdles runner girl with ischial epiphysitis. All kinds of epiphysitis are best detected on ultrasound. We need not go for MR, and these boys are not, they do not afford an MR, and even for a follow-up purpose. So we can see the cortical irregularity here again, which is seen on X-ray also. The X-ray was done later just to confirm these findings. This young wrestler, again thanks to Dangal movie, and she had something like shin splints. There is thickening of the periosteum over the anterior tibia and increased vascularity. Sibyl's disease, we all know, calcaneal epiphysitis in a young boy. So X-ray and ultrasound are Jay and Virus of the movie Sholay. So they have to go hand in hand, and ultrasound plays definitely a greater role and an important role. Take home message is ultrasound first. It is not just for academic interest, but it has a revenue tag. If we are doing, using ultrasound, it gives us both. I thank all of you. I thank the organizers, especially Dr. Mene and the, Department of MGM Medical College for inviting me here. Yeah. Thank you. Thanks a lot.
Wonderful.
Thank you very much, sir. I must say, wonderful case collections. Now we will proceed with case presentations.
In the time that our patient is coming, there are a few things that I'd like to just recap. Sameer's presentation has inspired me to show you a few more things. There is a very famous thing that was probably not so much importantly touched upon yesterday, the triangular fibrocartilage, and they're commonly called as TFCC. It's on the ulnar side. So I'm just going to demonstrate how we see a part of the TFCC. So we go on the ulnar side in a long axis scan. What we actually trace in that long axis scan is the tendon of extensor carpi ulnaris. As you need to remember back, it's the 6th compartment in the ulnar groove. So if you can really see right here, okay, so that's my extensor carpi ulnaris. And this extensor carpi ulnaris, when I make in a long axis scan, it forms a component deep inside at the level of the my TGC I need to arrange. Okay, and when we see the extensor, if you can now appreciate that entire pattern of extensor carpi ulnaris, the fibrillar pattern, I'm coming from the proximal end going distally, and what you see, the triangular area right here is the triangular fibrocartilage. This is how it needs to be compared with the symptomatic side. So what we see right here, again the same fibrocartilage as we see in the menisci, the triangular area, very beautifully seen, and then there is a slip that goes deep in between the ulnar and the carpal region, and it probably is something that needs to be evaluated if there is a deep tear or a deep avulsion injury. But this part of the triangular fibrocartilage is totally accessible.
Again,
and you should be able to
there is a breach in the continuity of the cortex.
Sameer showed a very nice
tear
and a thickening of the triangular fibrocartilage, and he compared with the normal one.
Intact,
so I thought that it should be shown. The other thing that probably yesterday skipped was a very nice ligament that is called as the ulnar collateral ligament. What is the significance? It's also called as the gamekeeper's thumb, where there is a hyperextension injury, and it's a skier's thumb, where there is a fall and there is a hyperextension injury, which actually tears the ulnar collateral ligament, which is present on the more on the dorsum rather than on the volar side or the palmar side. And how we evaluate for that is a probe orientation. We bring the head of the first metacarpal with the region of the proximal phalanx. And this thickening, do you see this? Do you appreciate this? This is what is the ulnar collateral ligament. Please do carry this image in your head, because when there is a tear of this, there is adductor muscle, the aponeurosis. This is the aponeurosis of the adductor muscle. And this adductor muscle actually goes and in a complete tear invaginates between the ulnar collateral ligament. And once it tears, it usually tears from the level of the proximal phalanx, takes an avulsion chip from here. There is an avulsion chip from the level of the distal attachment, and that avulsion chip retracts, and the aponeurosis actually invaginates, and that becomes a surgical case rather than a conservative therapy, very commonly called as a Stener's lesion. What is Stener's? When there's an avulsion from the bony avulsion and a complete tear of the ulnar collateral ligament. So this is again something which needs to be evaluated every time there is a fall on an outstretched hand, or the patient, why it's so popularly called as gamekeeper's thumb, because in olden times, the rabbits used to be a menace in UK, and these farmers used to actually break the necks of those rabbits with their thumbs. And so that was a gamekeeper. The guy was keeping an eye on the entire area, and every time he would just break the neck, his ulnar collateral ligament would go. So that's a short history behind it. Do we have the patients here? Or we go with the presentation and come back again for the patients?
I'm sorry, ma'am. There is some change in schedule.
Okay.
There is 10 minutes tea break, and then we'll continue with lecture.
All right. Okay. Oh, you should have stopped me then. Thank you. All right. Okay.